we wanted to talk a little bit about the more, I think what we did last time is we put some of the stuff in the general talks, and clearly it's a bit more specialty specific, so we've broken up and we'll try and make this interactive. So Andrew's going to talk a bit more generally about dialysis in AKI, and I'm going to talk about some specific scenarios, and particularly customization of treatments. You've already heard a bit about this landmark paper which described AKI during the Blitz in the Second World War, and I always think it's quite salutary to look at the quality of observation that was going on in 1943, including quite a nice pictorial representation of fluid therapy down the bottom here, and single figure measurement of urine volumes. Dialysis in AKI was actually invented a couple of years after that by this gentleman, Willem Kolff, in between fighting for the Dutch resistance. It's not clear whether he's going for his wallet or a gun here, and this is what the technology looked like at that time. So Andrew's wearable artificial kidney is sort of a big sort of downscaling of this. You'll hear probably a little bit about the evidence base around dialysis. Most of the renal support literature is actually critical care rather than intermittent therapies, although the ATN study, there is a fairly wide deployment of intermittent dialysis in critical care in North America, mainly because it's still controlled by nephrologists and the bill on a per treatment basis. So there was quite a lot of dialysis patients in the ATN study. This was the ANZIC investigators, and this was just really about dose intensity, so the amount of fluid we're replacing in CRRT and outcomes, and they showed no benefit between high and low intensity. So we've had a couple of New England Journal papers relating to dosage of RRT in AKI in critical care. Now, I want to make the important point here, and I'm going to compare CRRT. Some of you do CRRT in renal units. You'll certainly, as nephrologists, be asked for advice about people on renal support in ITU, and I'm going to explain how they work and how we customize things. But I think it's important, that paper that Ronaldo Bellomo just published there in the New England Journal a few years back, there were breakout clauses in the treatment groups, and customization would happen outside of protocol. So it's important to bear in mind that in those clinical studies, a standard dose rate, there is an argument which I like to have about whether dose-related, weight-related dosing of dialysis and AKI-RT is appropriate. It's probably better to go for therapeutic targets, metabolic and fluid, rather than rather like a blood pressure drug, we'd aim for blood pressure rather than just give a weight-based dose. But even that aside, that's what they did in that study. But if the patients were hyperkalemic or acidotic on the 25 mils per kilogram, they got their dose put up. They didn't allow them to move into dangerous territory metabolically. So it's important to bear that in mind. I think you will find many patients that are treated with AKI have multi-system problems, and there can be challenges around safely customizing treatment. So I'm going to go through a few clinical scenarios with you, and I'm going to look at CRRT and intermittent therapy. I'm not going to look at the hybrid therapies, hemodiafiltration, for the purposes of simplicity, and the sort of issues you'll face in some of these clinical scenarios. So this is a 50-year-old male who's presented with a history of chronic alcohol abuse. We heard a bit about this earlier. Jaundice, ascites, SBP. Fluid intake is poor. He's given dextrose as a maintenance fluid. Already at risk of hyponatremia. With this type of fluid strategy, becomes more hyponatremic. There's something in the there's some maxim around not giving sodium-based crystalloid to people with cirrhosis. So albumin has got saline in it, the hepatosis, so it's got the same concentration of sodium chloride as normal saline has. Okay, so if someone needs salt loading clinically, they can have it. But a lot of these patients are given dextrose. He's become more hyponatremic. He's got AKI, and it's got worse over 7 days. Sodium's dropped from 125 in presentation to 119, and he has metabolic decompensation here. Sort of slightly powerless blood pressure, some crackles on the chest. Hepatology team call as they feel the patient needs renal support. Do you agree with them? Does the patient need renal support? So I think that's not unreasonable, is it? He's acidotic with, hyperkalemia that could be described as potentially life-threatening. Okay, so what's the main concern here about in terms of customising? I guess the clue's in the title, but any concerns, any considerations about this patient before we just plug them on a dialysis machine?
Probably reversal of the hyponatremia.
Yes, so over-aggressive reversal of hyponatremia. So the major risk of RRT in this patient, I'd say, is the hyponatremia. Any other factors that might mitigate the risk? So what you're concerned about there is a change in serum osmolarity and it going up quickly. What else will be happening at the same time? Urea will be coming down, so it helps mitigate that risk. Any other things that are a bit risky about this patient? You're not. If you put this guy on dialysis, you're probably not going to sleep terribly well while he's on. A bit hypotensive, a bit of a bleeding risk. Okay. Slightly fragile generally, but hyponatremia needs some specific consideration. We've touched on that. So how would you do RRT in this chap? Does anyone have any ideas? Would you prefer continuous treatment over intermittent treatment? Okay, so yep, potentially. So there are some pros and cons, as I'll talk about. So this is what's happening in terms of urea and sodium during hemodialysis. So the urea reduction may partially offset the rise in sodium, although we'll tend to do a low intensity of first dialysis, and generally you see URRs about 25%. People often make the mistake with first dialysis of not putting it up after a few days. They're still on a small kidney for 2 hours, but we go for a low intensity dialysis to try and mitigate this risk of an overcorrection of sodium. We'll come back to that. So this is the danger. He might be here. He may have a slightly tight swollen brain because his serum sodium has dropped, his blood osmolarity has fallen, and water has moved into the brain down a concentration gradient. If we overcorrect him, we will see water move in the other direction. ECF osmolarity rises, water is sucked out of the brain, and we'll get an osmotic injury to the brain. That's a shrunken brain with osmotic demyelination that we can see here. So let's look at hemodialysis in hyponatremic AKI. So this would be the sort of standard situation. We have our dialysate fluid. We're accessing the extracellular fluid through the dialysate circuit, which is obviously in continuum with the intracellular fluid, but this is the compartment we're accessing in the blood. And a standard dialysate fluid would have that kind of dialysate sodium concentration. So clearly that's going to result in a brisk sodium infusion into the patient down the concentration gradient. The rate of that sodium infusion is going to be determined by the duration, how long, the size of the kidney, how much membrane we've got, the pump speed, okay, how quickly the blood is being passed through the circuit, and how quickly the dialysate flow is going in the other direction. We just denote those QB and QD. Okay, so we'll see rapid early diffusion of sodium. It's a small molecule, very dialysable. So what we do here? Well, if we want to avoid osmotic demyelination, we can go for a short therapy of 2 hours on a small, low-efficiency kidney with a low blood flow and low dialysate flow, and we probably cool the patient a little bit to afford some hemodynamic stability. Now, the aim is to facilitate safe correction of the sodium while achieving other therapeutic targets, which are getting potassium down, urea down, and if the therapy is inadequate, that can be extended in timing or frequency, but probably not intensity. And we need to monitor his electrolytes closely, and his GCS and his ins and outs. What about hemofiltration? Well, we can see here a standard bag of hemofiltration replacement fluid. Sodium's 140. So what are we doing? So this is a very different treatment. This is hemofiltration works much more like our own kidneys. We take some fluid out of the circulation, we modify it in the way out of in the urine, and the final composition of the urine is determined by our homeostatic needs. In hemofiltration, we similarly take some extracellular fluid out of the equation and we replace it with a replacement fluid. Okay, so all we're doing is filtering off some fluid. So in standard terms, we'd look at a 2 litre exchange. That's going to remove 238 millimoles of sodium. It's also going to remove urea, potassium, etc. And with a standard hemofiltration bag, we'd be putting 280 back in. Okay, so we're still going to get a sodium infusion in this patient. All right, I don't want you to understand, remember the precise numbers, more the general principles. So if we assume this kind of total body water, we do the maths and look at how the concentrations shake down. A 2 litre exchange will probably, depending on what's happening in terms of ins and outs, we'll probably put the sodium up by 2 millimoles per hour. And that's going to be too quick a correction. So our correction targets would generally be, we'd say not to exceed 12 millimoles per 24 hours to avoid an osmotic demyelination injury. Okay, so that's a bit intense, all right? So Ronaldo Baloman, who's studied, would not have put this patient into the trial, okay? So what would we actually do in terms of hemofiltration? Well, we can cut this down to a litre or half a litre. Half a litre would really be optimal, but as low as most places technically can go. This results in a much smaller 10 millimole net infusion per hour, and that will result in a correction of 12 millimoles per 24 hours. One could also pause the treatment, you know, if it was overcorrecting and we're monitoring. So the aim is again to facilitate safe sodium correction while meeting other therapeutic targets. If the therapy turned out to be inadequate and the sodium wasn't rising too rapidly, we could increase the exchange rates, or we could add dextrose to replacement fluid. Marlis has published on this, but I think this is a simple approach, and again monitor the patient closely. Severe acidosis. So a 45-year-old male, this is a real case, presents with general malaise, lethargy, vomiting, no past medical history, dry, hemodynamically stable. He is drowsy. Okay, so severe acidosis with AKI, so Bicarb 3. Now, any concerns here diagnostically? It's an out of the blue AKI with a very severe acidosis. Any thoughts?
With calcium ionized.
So the calcium. So that's a good question. So that is the total calcium. So so there's an issue here about hypocalcemia and correction of acidosis. You may precipitate. You will lower the ionized fraction, and you may precipitate symptomatic hypocalcemia. So that's a concern. Is anyone totally comfortable about this with AKI and a normal lactate? It's somewhat disproportionate, isn't it, to the other derangements. So anything else that could be causing the acidosis? It could be ketones. We can look at our anion gap, which is this white box. We've got our positives here, we've got our negatives here, the anions, and we use this model to interrogate the size of the organic acid box. Okay, and see what the gap is, the deficit. Bicarbonate contracts, that expands. So we can see here his anion gap's massive, it's 38. Now we will see a raised anion gap acidosis in AKI. You know, we're not excreting organic acid, but this is very high, okay? So any other potential causes of a raised anion gap acidosis other than ketosis or
drug overdose?
Yeah, drug overdose. Anything in particular? Okay, I think glycol's a good idea. Okay, so states potentially we see a bit less of that, but these are all good ideas. So respiratory alkalosis, then metabolic acidosis. So the states were negative. Potential causes of acidosis, we have renal failure, and we've touched on other causes of acid, exogenous acid. Therapeutic options as regards acidosis correction. Low calcium we've touched on already. And might the cause of his acidosis influence RRT initiation and modality selection? So if he did have poisoning, would that influence the way that you would treat him? Are there any advantages of CRRT versus hemodialysis for small molecule poisoning? Which is more powerful?
Continues to be more powerful with the small molecule.
So the opposite, I'm afraid. So we are going to do a poisoning session, and we'll go into that in a little bit more detail. How else can we correct his acidosis? Okay, we get dialysis, CRRT, and I guess the only other thing to do would be to give him some bicarb. Yep. All right. So let's have a look at that. So his total bicarb deficit. If you take what his bicarb is, 2, and what we'd like it to be, just normal, 22, that's 20. This diffuses across the body compartment, so if we multiply that number 20 by his total body water, which we can get, that's his weight times 0.6 or 0.7, we get 1300 millimoles, okay? So that's quite a lot of treatment, all right? So that's 18 polyfusers of that stuff. Small kidney, we might get his bicarb up by 10, with a small dialysis. With this, if we use a lactate-based buffer in the replacement fluid, we'd need about 20 exchanges. That's assuming he's not producing more acid. That's just to clear the bicarbonate deficit that's already there. Does that make sense? Okay. So how would this work? So we've got, in dialysis, we've got bicarb in the dialysate fluid, okay, and we're contacting with the ECF through the membrane, so we get a bicarb infusion determined by the duration, size, pump speed, and dialysate flow. Okay? So it's a bicarb infusion. Hemofiltration, lactate generates bicarb. We can use bicarbonate-based hemofiltration solutions. So he's got 2 millimoles of bicarb in his ECF. So we'll take out 4 millimoles with a 2 litre exchange. We'll give him 60 back with a 30 millimole bag if it's 2 litres. So he gets a net infusion. So it's quite a good thing to remind intensivists, that 1 2 litre exchange is roughly similar in terms of the bicarbonate infusion delivered as one of those. Okay, so they generally are very resistant to the idea of giving bicarbonate, but then you actually point to the bicarbonate that's been given on the hemofiltration machine. So you can show them up and look clever, which is a very important thing I find in life. So he's going to need about 20 exchanges like this. And he actually had ethylene glycol poisoning. This is glycolic acid. This is calcium oxalate crystals formed downstream from glycolic acid. Ethylene glycol comes in, it's metabolized to glycolaldehyde onto glycolic acid. This causes an osmolar gap, this causes the anion gap. You may have both. If you're late, you'll just see the anion gap. Osmolar gap. We used to measure alcohol toxicity that way. Now we get blood alcohol levels. Glycolic acid gets metabolized to oxalate. This is effectively a poison, precipitates with calcium in the kidneys and causes organ problems and soft tissue calcification, etc. Alcohol competes for use of this, so it's helpful, and fomepizole inhibits it. We had a very successfully treated case of this recently. So suspect ethylene glycol unexplained acidosis with a raised osmolar gap. Dialysis, the criteria is if there is significant acidosis, AKI, or deterioration in spite of other therapy, one should dialyze. Glycolic acid has a long half-life but a low volume of distribution and is small, so this is highly dialysable. You will clear much more of this with a dialysis machine than you will through even good native clearance, and this guy is already in AKI. And you dialyze out the whole pathway. This is great. So you'll dialyze out this, and this. Okay? So whatever point in the pathway he's at is helpful. CVH much less efficient at clearance of these molecules. So what would have been a fatal case of this quite recently who's survived. So what would be the optimal treatment here? So this is completely the opposite if we've got poisoning. So Andrew talks about this, you've only got one shot at this, okay? I would say, you've never got too little poison in your body, okay? So there are some risks to doing high intensity dialysis, disequilibrium and things which we've discussed. But what we need to do here is get rid of poison. So we need to do a high intensity treatment, 8 hours of treatment, maximise blood flow and dialysate flow, cool the patient, support the serum calcium as per your point, and we'd probably use a dialysate bicarbonate of 13 and potassium 3. So we'll use more physiological fluids. If we put him on with potassium of 2 in the dialysate, it will be 2 when he comes off after 8 hours of that. Okay? So, I think we can say that hemodialysis would be a superior treatment in this context as the patient has been poisoned. But if the cause was not poisoning with a small non-protein bound molecule, CRRT for such a profound metabolic defect would probably be the preferred treatment. But here we have to prioritise poison removal. What about uremia? So, a 70-year-old male presents generally drowsy and unwell. Has a background of vascular disease, diabetes and refractory myeloma. He's had CDT and Velcade. On presentation, he's drowsy and confused and hemodynamically stable. This is again a real patient. So these are this guy's numbers. So urea 1880, creatinine 1600. He's acidotic, sort of lowish calcium. Develops coffee ground vomiting. Does this gentleman need renal support?
You probably want to talk to his family about what his wishes were beforehand, potentially. Some irreversible stuff in there as well.
Yep, so ceilings of care, that's an important thing to raise. Let's just assuming there's currently no ceiling where you think this might be reversible. I agree it may not. This is likely to be myeloma kidney. You're going to hear a lot about myeloma tomorrow if you come to that workshop. So I think you'd say that if we're not limiting or putting ceilings of care, he would need renal support. Okay, what's going on here? And I don't mean the newspaper in the background. So this was him. So what's happening there? So he has uremic encephalopathy, certainly. So the susceptibility to uremic encephalopathy, I think with metabolic and fluid decompensation in AKI, there's what's actually happened to the patient and their tolerance for it as well. And I would say that uremic encephalopathy, we see a lot more of this in more elderly patients, patients with diabetes, with small vessel disease, and particularly the combination of those things, AKI and sepsis, they will often get a flap and get confused very quickly. Okay, so we know that he's got uremic encephalopathy. We know he's got uremic osmoles in his brain. De facto, he is at risk of dialysis disequilibrium. Okay, so what is the major risk of RRT in this situation? Is dialysis disequilibrium. Okay, reducing the ECF osmolarity. There's a drag before the osmoles in the brain come out. During that time, water moves into the brain because of the blood-brain barrier delay. Does that make sense? Yep. Okay. So clearly the dialysate has got no urea in it. His is 80. Okay, so all that urea is coming out. But what are we going to do here? We're going to use a small, low-efficiency dialyzer. We're going to have a low blood flow, low dialysate flow, a short dialysis. We're going to put our dialysate sodium up. We can go sort of 10 higher than the serum. We should be able to hit that. 148 is about maximal, and that will help offset the reduction in urea. Okay. What about hemofiltration? Okay, so again, we're going to do a more cautious therapy. So I would always recommend the intensivist do a 1 litre exchange to start with. And if we do a 1 litre exchange, a 1 litre exchange will decrease the urea by 1 to 1.5 millimoles per hour. So that's probably acceptable. We can always slow down. Urea production will continue, may vary according to the metabolic state. Monitored GCS. You can always reduce the exchange even further down to 0.5 litres. He's at high risk of bleeding. He's actually had a bit of a GI hemorrhage, so we can think about citrate-based or non-heparin-based anticoagulation strategies in CRRT. So I think CRRT would be preferable when we're really concerned about dialysis disequilibrium. It's a more controllable, more modifiable, slower treatment. Even if if you get the dose wrong, you've got time to change it because it's a 24-hour prescription rather than something that's given in a spurt over 2 hours. Okay, but if we actually did ward-based dialysis treatment along the lines I've described, but hand on heart, I'd say probably if there weren't resource issues around critical care, etc., we would prefer that option. What about the potassium? Okay, so severe hyperkalemia, 85-year-old male, history of CKD, ischemic heart disease and LVF. He's maintained on lisinopril, furosemide and spironolactone. Chest infection, he loses renal function, okay, and his potassium's 8.4. So pneumonia in a CKD patient with lots of risk factors for AKI comes in. Why is his potassium so high? What's that? So spironolactone, certainly, okay, takes a couple of weeks to wear off, and this completely blocks out your tubular potassium excretion. It's all aldosterone dependent, that bit. So he's lost GFR, he's on an ACE, his total body potassium is extremely high, and spironolactone is going to take a long time to wear off. This wasn't his ECG, but it did look like that. So broadening of the QRS, it slows down depolarization because potassium can't exit the cells into the ECF because it's pushing uphill against this very high ECF potassium. That's calcium gluconate. Okay, now this patient was actually managed medically and subsequently had a cardiac arrest, but I would say that this was an absolutely compelling indication for immediate renal support, severe hyperkalemia in the context of, so life-threatening hyperkalemia in the context of aldosterone blockade. So, non-renal support, well, you can have some bicarb, you can have furosemide, you can be salinated, and you can have insulin and dextrose. In terms of the modality and delivery of the RRT, we'll get onto that. Just a reminder, this is the tubular epithelial cells that push stuff into the urine in the last bit of the kidney, and all this potassium exit machinery is all aldosterone dependent. So we're not delivering tubular fluid because his GFR is down. What little is getting there, all this machinery is being blocked off by the spironolactone. So let's say we've got a DASI. So the key thing is here, this man does not have a cardiac arrest from hyperkalemia. So we can start by going quite intense. So we want to go high intensity initially, okay, and we'd obviously use the potassium in the DASI is low. And then we can step down a bit when his ECG changes have gone, and then we move into a phase where we actually have a situation where we're going to see rebound hyperkalemia, and at that point it's worth slowing down and allowing the potassium to equilibrate between the intracellular and extracellular compartments. Key thing is it's rather like a poison, we will see rebound. Okay, the dialysis can only work when this is high. Okay, so as soon as we knock that down, I mean, we probably wouldn't knock it down to 2, but the gradient and speed of it will come down pretty quickly. So we would want to do a repeat dialysis very early on, and once we're out of the life-threatening situation, we would try to do a more extended gradual treatment. Okay, so it's I advocate a 2-phase approach here. But when we've got this, we've got to go all out early on. So I'd say here hemodialysis is the optimal therapy in this scenario. Potassium is going to be much more rapidly cleared by dialysis than CRRT. But if he is stuck in a critical care context and can't access dialysis, we would want to do high volume exchanges. Okay, so in Ronaldo Bellomo's study, if he had a patient with a potassium of 8.4, he would not put that patient on 25 mils per kilogram per hour and just hope for the best. Okay, it would be a high intensity treatment to start with till we've got metabolic safety. A couple more quickies. Hypernatremic AKI, 77-year-old female presents collapsed, drowsy. Okay, this is the other way around. She's got AKI, uremic, sodium's high. Is RRT indicated? Well, I think we'd probably try not to here. But say she remains oliguric, what do we do about it? So here urea and sodium are going in the same direction with a dialysis treatment. Okay, so quite high risk for dialysis disequilibrium. So again, you know, we're going to go low volume CRRT exchange. That'd be the optimum treatment for her. Low amounts of sodium removed, And if we went for a 0.5 litre exchange, you know, we'd get that type of sodium correction. So again, we'd aim for a change of no more than 12 millimoles per 24 hours. If we did dialysis, we'd be back down to the opposite extreme, short therapy, small low efficiency kidney. Does that make sense? All that, okay? When to start? These are sort of really just very short vignettes. When to start AKI dialysis: 26-year-old with lymphoma, recent chemotherapy on allopurinol, hyperuricemic, becomes oliguric, develops AKI with a phosphate of 4. Your diagnosis would be tumor lysis syndrome. Okay, so the metabolic burden here is massive. Okay, we don't do creatinine-based dosage. What we're treating are the metabolic complications, and we can see here the phosphate is extremely high. So in this patient, I would say we're going to start dialysis with a creatinine of 130, okay, because we need to clear phosphate. So I would recommend, certainly unless it's falling rapidly, a phosphate of more than 4 in tumor lysis syndrome, get in early. You're losing renal function very quickly. There's the potential for irreversible calcium phosphate deposition in renal and other tissues, and one can get permanent dialysis dependence in this context. Okay, so when you start is dependent on what the other principal metabolics are showing, and they may be influenced by many things. In this case, we've seen, you know, massive breakdown of lymphomatous tissue. What is the right dose? Here's a patient with burns, multiple trauma, AKI from rhabdo, has been put on the standardized regimen of 25 mils per kilogram per hour of CVVH, but has remained hyperkalemic and acidotic with a high phosphate. Are they on the right dose? Okay, so this patient's metabolic demands are very high, so this isn't enough. We need to turn it up. Okay. This is the opposite. 65-year-old post-cabbage, 48 kilos, prolonged respiratory wean, wounds fully healed. Okay, low metabolic demands, having 2 litre exchanges per hour. You'll notice there's sometimes daily intravenous phosphate supplementation. Okay, so it's just been kept on the 25 mils per kilogram per hour. The metabolic demands are much lower. So this creatinine of 60. So this patient needs to have their CRRT replacement dosage turned down substantially. Okay, so some concluding remarks before I hand over to Andrew. In AKI, we have a range of powerful extracorporeal treatments that may be deployed to alter ECF volume and characteristics. That's what we're doing. We can do great good, but also cause great harm. RRT in AKI is used to replace renal function or support renal function if it needs help due to volume or metabolic decompensation. This may be due to supply or demand, loss of renal function, or overwhelming demands, and sometimes both. Mitigate risks of treatment, so cardiovascular instability, dialysis disequilibrium, hemorrhage, iatrogenic electrolyte abnormalities caused by dialysis or overzealously corrected by dialysis. Deliver optimal care for the patient as a whole, taking into account non-renal support and the health and function of other organ systems. We can optimize or modify all these things. We can pre-optimize the patient, give them some dextrose, etc., resuscitate them. We can choose our modality, we can choose the dosage, the duration, and the timing of withdrawal. We need precautionary measures, including monitoring and appropriate escalation. Not all renal support is extracorporeal, okay, so we do have other treatments like bicarbonate. You should understand what you're doing with those treatments. And I think the withdrawal of renal support occurs when the balance of supply and demand is right. Okay, we've got enough renal function for our metabolic or fluid demands that we can do without it. Don't forget symptoms, read the studies, but tailor your treatments on an individual basis as in any therapy. And I'll stop there. Thank you very much.